Welcome to the A to Z Running Podcast, where we help runners thrive. I'm Andy.
And I am Zach. And up next, orthopedic surgeon Dr. John Maskill discusses Achilles and Plantar fasciitis. And after that, World of Running updates about an interesting policy, New Balance races, and London's 2023 historic field. Glad to have you with us once more. If you missed it, last week was our end-of-month Q&A episode, which means you got to wait another month until the next one. But the good news is that's plenty of time for you to get in your questions that you have for us about anything to do with running, training, running-related things, training-related things, and all the stuff. And so, if you have questions and you want to share them, the easiest way to do that is to go to AtoZrunning.com/question, and we will drop your question into the queue for the end of this month and answer them on air.
Before our Q&A that we did, our listener Q&A, we were talking about toughness in Steve Magnus's book, Do Hard Things. And we had a great comment from a listener. It was Liz. She wrote, I've listened to last week's podcast during my last 4 workouts, 2 runs and 2 bike rides, and will probably listen to it a dozen more times over the next few weeks. Yesterday's race was the first time I tried to put some of the steps into practice, and it had a big impact for me. Thank you for continuing to dive deep into this topic. I hope everyone else is getting as much out of it as I am.
You are welcome, Liz.
I hope so, too. You know, it's a tricky conversation when it comes to the area of toughness and confidence and practical things that can surround kind of these intangible topics that we have that come up in running that are so important. Our mental state is so important. So to have some handles on it and ways to improve is just really valuable. And so we're glad to bring you the research. We're glad to bring you the brilliant minds like Steve Magnus so that you can we can help you thrive, which is our point here at A to Z Running.
Also, it should be noted that, to Liz's comment, it's pretty much the norm for everyone who listens to this podcast to listen to each episode dozens of times. And so if you don't, chances are you're not doing something right.
Oh, my word.
That's what you should be doing.
So Zach is doing his sarcastic thing again.
That's not sarcasm. Just a little bit of hyperbole.
Yeah.
Just a little bit.
A lot of it.
Speaking of great things, there was another recent comment. So this is a bonus comment we wanted to share because it came down on YouTube. We got to honor it. Anytime someone comments on YouTube, we have to
the YouTube comments.
To honor the YouTubers. Those are the diehards who actually look at our faces. Well, hopefully they don't look at our faces and they just listen while they're doing something else.
You can't
and
do
use
that.
YouTube.
You can listen, like if you have YouTube Premium, which my sister has YouTube Premium, she listens to the podcast via YouTube. Then if you close YouTube, you can still listen.
That's not an endorsement for YouTube Premium, though, because I personally think it might be a waste of your money if you have that. But
for listening to podcasts.
For listening to podcasts.
If you do other things on it, then you have other content.
I don't really know because I know nothing about what YouTube Premium has to offer.
That's true.
So let me share this comment. This one came from Escantos, or whatever the user handle was that looks like Escantos. And said, I agree with your comments about down weeks. We were recently talking about down weeks and whether or not they should be implemented in a regular kind of sense. And we said no, that it shouldn't be like a planned thing you do every so often for many reasons. If you're not familiar with our argument, you can go to episode 169 and listen. But this listener then said, down weeks happen to me due to life circumstances and illness. And down week planners may say you're getting sick because you're not taking down weeks, but I honestly don't train hard enough for my exercise to have a negative impact on my immunity. That's an honest comment. I appreciate that. If I took planned down weeks and then had unexpected down weeks, it would be down weeks half the weeks. And that's not really the goal. So in that case, I can see the point.
Right. And to give you kind of a summary of what we said, down weeks do happen. And if we're responding to our training and we're listening to our bodies, they're going to naturally occur. But if we schedule them instead of having it be a response to what we're doing, it won't be at the ideal time or in the ideal way.
Necessarily.
Yeah, necessarily.
So whatever the case may be, we always appreciate your comments and reactions and reflections. And insights. And so appreciate these listeners and the many more who are sharing thoughts in all of the places you share them. And continue to do that because, you know, then we might just throw your name and your comment up on the episode and feature your words. Speaking of words to feature, we've got a great conversation coming at you next. So let's get started.
Our guest today is Dr. John Maskill. Dr. Maskill specializes in comprehensive foot and ankle treatment and reconstruction. His active involvement in research projects, publications, and presentations on a local, national, and international level puts him at the forefront in his field. As a resident, teacher, and mentor at the Grand Rapids Medical Education and Research Center, he is also committed to sharing that knowledge with the next generation of physicians.
And he doesn't ever sleep, which means he has even more time than most regular
That's what we learned
humans
about him.
for all the good things he's doing. Speaking of John, he told me to call him John, so I'm going to do that. He also is a great personality in conversation about these kinds of things. One of the things that I've always appreciated about him is that he doesn't just like talk science at you. He like engages with you in the things you're talking about. And that's always lots of fun. So you're going to get plenty of that. But the point here is we were trying to get to the bottom of the Achilles and plantar fasciitis issues that so many runners seem to have, the chronic problems that we just can't quite shake and they just never go away. And so I wanted to get a surgeon's take. We know John from our own experiences and because he's nearby and around and also happens to be a friend. And so we thought, what would be better than talking to the guy who like is the one that has to solve the problem when it's at its worst. And so one of my questions that you're going to see very early on is what can we do to prevent the problem from getting to the point where we have to call you, John? And he has a lot of great things to share, but keep in mind that in principle, when we're talking about these kinds of issues, they are all very different for different people in terms of when and how they develop over time. But there is some sound advice here that is true for every single person, runner or not, to try to help address these types of issues.
And John does see a lot of runners with these issues, and that's why, this is such a relevant conversation. But also, John has become a runner himself, so it's been really fun to chat with him about training and running too, and this is going to be a great conversation.
All right, well, let's hear directly from the doctor himself. All right, here with Dr. John Maskill, and we're just going to call you John for the rest of the time. That's all right?
Please.
Good. Well, thanks so much for joining. So one of the things we've talked about with our audience and why we're having you on now is we share what we can about what runners should know about certain things, but we find that when you can bring the person who is actually the one doing it and have them talk to runners about it, it's that much better of a conversation. So we're going to do that today. But before we do, would love to get your background a little bit and what brought you to today doing what you're doing.
Okay. My name is John Maskill, and I'm a physician with Orthopedic Associates of Michigan. I am an orthopedic surgeon, and I really chose orthopedics because I love doing surgery. And I love taking care of healthy people. And so I loved orthopedics because, you get an injury for any reason. And, it's my job to get you functional and walking again, running again. And I'm dealing with someone who's not super sick. So I see my results instantly. It's gratifying from that standpoint. Then we get to subspecialize if we want to. And I chose to do a fellowship with a guy named Greg Pomeroy up in Portland, Maine for a year. And that's a subspecialty year, so we only do foot and ankle. And then I was hired by Orthopedic Associates 15 years ago. And since then, been training residents and now have my own, with my two partners, foot and ankle fellowship that we run as well. So we're teaching other orthopedists foot and ankle as well.
Yeah. When this is not a question I prepared you for, by the way, but I'm just, feet are complex. And from the runner perspective, everything lives and dies by whether your feet can do that job. Is it, in that sense, is there a unique challenge to something like foot, ankle versus knee versus hip, or they're all kind of, certainly important, but there's nuances. Do you find any of that with like why you like to do feet and ankle versus something else?
Yeah. Foot and ankle, not to, make myself sound any better than the next orthopedic surgeon, but the one thing about foot and ankle is that, there's so many bones sitting below the ankle. So for the ankle to work right, the foot has to be in this proper alignment. And not to mention, you have to just have everything working just as is, and it has to be working perfectly. So when you have somebody that is running, you're going to see any one of these number of joints that are going to flare up. And especially when you're doing it excessively with several thousand steps at any given time with no break.
Right.
And so it's different than having, for example, in your knee and your hip, there's one joint, one relative way to move, flexion, extension, right?
Yeah.
And there is some rotation there, especially in the hip. But in the ankle, you're dealing with inversion, eversion, uneven ground potentially. And then you're dealing with dorsiflexion and plantar flexion. And then you also have to have this foot land evenly on the ground so that you have even disbursement of your weight. And so all of that just adds a lot of complexity.
That sounds like it. That absolutely does. Yeah, if I can, there's one memory that always stands out to me. You had operated on a family member of ours in his foot. And I think we were having dinner perhaps with Andy's parents, and you pulled out your phone and started showing us pictures. And I just remember thinking like the amount of excitement and enthusiasm as you're showing us the inside of this guy's foot. I'm like, this is cool. This is a special interest, a special skill, but certainly your energy and enthusiasm for the work you do and for the people that you're helping has always been evident. And so if there's one thing, yeah, definitely. If there's one thing that just, as I think about like why we can appreciate, certainly the care that comes with the work for medical professionals, that's something that we've always enjoyed and appreciated about you particularly. So on that level.
That's awesome. Thank you. That's a compliment.
Definitely. Now, that being the case, we're going to tap into both your enthusiasm and your expertise today.
Let's do it.
It's going to be loads of fun. So this first one's near and dear to my experiences. We're going to talk about Achilles, plantar fascia, plantar fasciitis, and being one myself who has had a kind of slight chronic Achilles problem. It tends to be one of those things for me that if I'm not careful, especially if I'm not addressing mobility and flexibility, then I know that the Achilles will come back at some point. It'll start to get sore, and then I'll have to take a week off running if I don't address it. And a lot of our listeners, because they've said it to us, have similar experiences. Then, take it all the way to the extreme where we were talking earlier about a friend of mine who's had multiple Achilles surgeries, and certainly others listening have experienced, the final solution with their Achilles. So we want to try to address here, thinking about if the Achilles pain is there, what are the options? What are the results of surgeries as one of those options, and what else is available to us? But why is it happening as well? And as runners, what do we need to be aware of to know whether this thing is something we should do certain things about? So let's start with, you were saying earlier, what happens when you operate on Achilles pains or Achilles, and what choices do you make when you're deciding whether to operate?
Yeah. Well, I would say that if I could say that there's one more frequent injury with runners, even right up there, I would almost say that this is more frequent than a stress fracture. And that would be Achilles tendonitis or plantar fasciitis. And it doesn't even have to affect the runner. In other words, it's that frequent. And the reason being is that, you as runners are all athletes, and you guys run. And the product of that is that, we end up gaining musculature, and, we end up also having multiple episodes of repetition, right? And so, we know that running is a repetitive thing over and over and over, and we need our structures in our foot, ankle, and limbs to essentially be able to accommodate that. So what happens as you become a better runner, or as you continue to work out, you're building your training, you get your result that you want. You get your stronger calf muscle, and you get better bone quality, etc., because you've trained your body to do that. The problem with gaining musculature, specifically in your calf, is that as your calf gets bigger, it functionally gets shorter, right? So you can understand that this thing is getting bigger, and then the actual tendon itself then starts to draw up, almost like, because it's just getting bigger. Yeah. And then on top of that, not only do you have more musculature, so it's pulling harder, but you also have, as you then run through your actual routine for this given day, your muscle then does what it needs to do. It actually needs oxygen. The only way it's going to do that is to get blood flow. Blood flow in this case is going to engorge it, which essentially increases the size of the musculature yet again. Okay. So now you have a situation where you have an Achilles that's functionally getting shorter. Okay. And then, because you've been working out and you're doing everything right and you're gaining the muscle, but then as you go through your daily routine, through the minutes of running, your calf is then going to then get that much more shorter, because you're going to give blood flow to that calf, and it's going to get even bigger for a time. And then it will decrease the blood flow as the muscle needs less oxygen. So what happens is it's going to pull on the Achilles harder. Okay. And so what ends up happening is, over the course of that many steps, you end up massively irritating this. And so the one way to counteract this is to essentially stretch out that new muscle that you've gained. And I know everyone loves to hear, especially runners, have you been doing your stretching? Have you been doing your stretching? But in reality, it really is super necessary, because the Achilles can only stand so much. Mm-hmm. And then, as you were mentioning before, you kind of threw in plantar fasciitis, and all runners know that plantar fasciitis is nowhere near the Achilles, right? It's underneath on your heel, and it's really far away from the Achilles. But if you look at the Achilles at the insertion, it comes right down and it inserts onto the back of your heel bone here, but then it continues underneath the bottom of the foot into the tissue known as the plantar fascia. And so what happens is, if you can kind of just picture a foot sitting on this platform like this, okay? And as we run with every step, we kind of do this, okay? Well, then just imagine the Achilles, if it's attached back here and it's being pulled up really hard, okay? So then now you get this massive collapse, and it only happens for a short time. But what happens is the plantar fascia is the band of tissue on the bottom, and it comes together into a massive wad and inserts into the heel. And so this wad is what feels this massive push downward. And so it ends up getting massively inflamed. So if you think about it, plantar fasciitis is most definitely related to Achilles tendonitis. Mm-hmm. And these two kind of groups of disorders, so to speak, are then directly related to the calf tightness and the calf, essentially the size of the calf too, really, and just how much pull and force it has.
So is it an oversimplification to say, I'm kind of intentionally trying to make it an oversimplification, but so someone says my plantar fascia's sore or tight, I've got this chronic Achilles problem, to simply say, just stretch your calf more, is like would that likely address the problem in most instances? Oh,
absolutely. And so
that's good to hear.
And so, like you said, I always feel like my Achilles tendonitis is going to come back. Yep. Or my plantar fasciitis is going to come back, and it will. Okay. But that is a testament that your calf is going to go through periods where it's not as stretched out. You know, you didn't do as much running or, you know, you did not stretch as much. Okay. And for whatever reason, your activities of daily living, you know, you're not getting as much of a stretch. And we've all been through those times where, you know, you think you're stiff for a second and, you know, you're just, you overdid it or you did an extra long run. And, you know, so those are those scenarios where that can happen. And we go through life and your Achilles is going to experience different, you know, tensions. And most of the time, 99% of the time, it's great. But then you have a runner who's really stressing things over and over and over several thousand times in one given run. And it's blown out of the water.
Yeah.
You know?
Yeah.
And so maintaining that stretch on a very daily basis and making it really intentional is critical to keeping those away because they will creep back. And so for me, I've had plantar fasciitis and I got this idea in my head that I was going to, you know, start practicing what I preach and start running. And, you know, so I went right out of the gates because, you know, I, you know, do things overboard as well. So I start running and the first thing I get is plantar fasciitis. And I remember being on vacation, I could hardly walk. So I start, you know, I had it for a week and I knew what to do. So I started right away. I stopped activity and started stretching the daylights out of my calf. And in particular, what you want to do is you want to really make sure that your knee is straight and then get that deep bend. And you can really feel that particular muscle, it's called the gastrocnemius muscle, stretch out.
Yeah.
And the reason that that muscle in particular gets cranky so easy is because it's one of the few muscles in the body that crosses two joints. So it crosses your knee and actually inserts into the back of your femur.
Okay.
Okay. And it crosses the ankle and inserts into the heel bone through the Achilles. The muscle that sits right in front of it is called the soleus. And the soleus muscle does not cross the knee. It only crosses the ankle. Okay. So that partners with the gastrocnemius muscle to form the Achilles and then insert into the heel bone, the calcaneus. But the one that's most frequently bothered almost 100% of the time is the gastrocnemius muscle. And that is the muscle that's the problem. And again, it's because it crosses two joints. So, I mean, if you have any issues in your knee, even the road that you're running on, okay, where maybe that side is further down the slope and has to just straighten out a little bit more or doesn't straighten out enough, for example, then it'll tighten up on the run because it does not get a full stretch in the normal in the normal routine. And so if you're working that muscle, it will tighten up on the run, you know? And so in you know, running in the center of the road, the best place to run, you know,
I do
those types of things come into play for that reason. Right.
Yeah. Right.
So
that's fascinating. So you get into kind of a scenario here where you haven't addressed the things you should. Things are progressively worsening. At some point or another, the dreaded surgery word comes up. And you have said to me that surgery for Achilles problems is not necessarily the first thing you want to do.
Right.
But let's start with what it looks like and then maybe why that's not your first choice in every instance. So what do you do when you operate on an Achilles? There's a couple different possible problems. What does it look like?
So let's say, you know, we're going to, you know, we've kind of failed all of these things, you know, and we really want to get to the surgery portion because nothing has worked. Yeah. Right. You know, then it's a sit down discussion. Okay. And you hope it's a sit down discussion. And I say that because, you know, I've talked to multiple people where they are told your next greatest thing is going to be for us to proceed with surgery. And you're going to feel like $1 million afterwards. And so part of the passion for being on here with you today is, you know, I'm a surgeon. I absolutely love to do surgery, but I care about my patients and what they want in life out of it, right? Because I'm not going to have anyone coming back to me if I just, cut on people and don't get the results that they want, right?
Right.
And so, when it comes to surgery, the simplest thing to do is to actually release the muscle I was just talking about, which is the gastrocnemius muscle. And very simple surgery. In normal patients who aren't runners, who are everyday people walking around, we go to work, we get up, we're moms, we're dads, we're students, we're whoever, this procedure does phenomenally well. The success rate for satisfaction to relieve for specifically plantar fasciitis and arch pain is 93%. I wrote a paper that is now recognized by the Academy of Orthopedics back in 2010. And that is the surgically described answer now for plantar fasciitis. It's on our boards and everything.
Yep.
So the release of the calf muscle has a 93% satisfaction rate of, fulfilling that person's needs. And in fact, we actually did a visual analog scale in that, in that study, and the pain went from an 8.2 down to a 1.9 with just the simple release of the calf, right? Wow. And so patients do get phenomenal results, but what you have to ask is then, what is the consequence of that surgery to that person? Like I said, most people love it. They come in crying because they're so happy that they can walk and they can do their job.
Yeah.
But the runner, in my experience, is this, question mark. Okay, we don't know how they're going to react. And when I say react, I don't mean, are they going to be angry or not? I mean, we don't know how their calf is going to respond. So what the surgery does is it actually lengthens the tendon, but it resets the muscle fibers of the gastrocnemius muscles. So that person could have zero problems, have zero pain. And in some instances, I've done this in collegiate athletes, high school athletes, and I get postcards from them that they've made most valuable player, right? So in other words, I've given them their athleticism back, and they are happier than happy, okay? But then there's another group of patients that when they go to run even after their kids from a car that's coming, they feel like they're impaired because their calf immediately cramps up.
Yeah.
And they go into a Charlie horse and they're frustrated by that. And yet they don't have pain from their heel.
Yeah.
But now their calf, I've switched a problem. Now their calf hurts.
And you were saying earlier, do you know why that discrepancy is or how?
Right. And so I do not know who that person's going to be.
Yeah.
And so it's not even necessarily the most athletic person. I can guarantee you're going to have a problem or not have a problem. Right. I mean, I don't know who it's going to be, and we have not figured that out yet. We aren't smart enough yet to have identified that patient population. So I get really nervous about that. So I say to my patients, we might win and we might not win, but you need to be willing to actually give up your running career. And most of the patients that are sitting in front of me at that point say, Maskill, I can't run anyways. So, I mean, what difference does it make? I mean, right now I'm in pain and I'm walking, but if I can be in no pain and walk, great. If I can run, it's a blessing, right? So those patients are, that's what I mean about the discussion. They're well informed in my clinic. I make sure that we have that discussion so they know what they're getting, because it's terrifying. It would be terrifying for me to have a patient that doesn't see those, that doesn't know about those complications, if you want to call it one. And then I realize that I've taken that from them.
Yeah.
So
that'd be heavy.
Yeah. Right. So, that's for plantar fasciitis. But in talking about Achilles, the surgical option is a little bit more daunting even still. So, the quick and easy, the quickest return to function for an Achilles procedure is going to be a scenario in which, as we talk about insertional Achilles tendonitis, it's typically created by a bony hump on the back of the heel bone called a Haglund's deformity. Mm-hmm. And if you can picture the Achilles being this hand, and what it does is it digs into the actual Achilles.
Yeah.
With every step. Every time you dorsiflex your ankle, this will essentially dig right into the Achilles like this. And so the treatment option is then to go ahead and remove that. Mm-hmm. And you also have to remove a diseased portion of the Achilles as well, because the Achilles, after multiple repetitive hits, the body tries to repair it, and it does kind of a lousy job at it.
Sure.
And so you have essentially scar tissue that occurs, and it can be read on an MRI as a partial tear. You might have a partial tear, but a lot of fluid around it typically, and it looks like different tissue. And physically, it is like a congealed tendon, so it almost looks like it's a block of scar.
Yeah.
So you cut that out and try to get back to healthy tendon, and then you also remove the Haglund's deformity.
Yep.
Both of which don't remove the entire Achilles from the bone.
Okay.
So you still have an Achilles that's wrapped around your heel bone like this, and this whole area is irritated. And whenever there's irritation, there's a change in the tendon because your body's trying to fix it. Yep. And so after I do that procedure, you're still left with the residual inflammatory tissue that I can't get rid of without taking your Achilles off the bone. So then moving on, if that doesn't work, the Academy of Orthopedic Surgeons says even, the most efficient way to get rid of insertional Achilles tendonitis is to do a full debridement.
Okay.
Which means taking it off the bone, which means cleaning all of that tissue up, and then I have to reattach it back to the bone, and then you as a patient have to sit there and wait for 8 weeks while that repairs, and then probably another couple of months even after that before I can let you actually run. Yep. The research actually shows that after 12 weeks of recovery after a surgery, a tendon has only 25% strength as it did before you took it off.
Yeah.
Now it's going to continue to keep remodeling, but it's taken 12 weeks to reattach, and it's only 25% the strength of what it was. So you can imagine the load that you're running up a hill. The Achilles is seeing tremendous load. It could re-rupture if you run too early.
Yep.
Right. So these are options that to a runner is to keep running. It's not really viable.
Okay. So that's kind of the reason you would take the option that isn't the perfect solution necessarily.
Yes.
But it's a better way to keep you in the sport.
Yes.
Okay.
Correct.
But in all of that, the surgery option sounds like it's not ideal for the runner who wants to continue in the sport in any of whether it's plantar fasciitis that I'm trying to operate or something with Achilles.
Correct. Especially someone who is able to still run.
Yes.
Okay. So if you can't run,
right,
and you say, Maskill, help me run again. Well, that's a different story because I got to get you what I need to do is help you realize that you can't walk without pain.
Right.
So surgery is a great option for you.
That makes sense.
Right. Yeah. But if you are a runner and you're like, Maskill, I'm annoyed by this particular area and I need some help here, then I'm going to say we are not doing surgery for any reason.
Yeah.
And don't let anyone try to convince you otherwise.
Yeah. Good. Okay. Well, so what we've talked about so far is from the spectrum here is stretch your calf or have surgery. But there's things in between those.
Yes.
So what does that look like, and when do you decide this is what you should try next first or yeah.
So, in the setting of running, I can't stress enough to literally make sure that you stretch stretch, especially if you love the sport, right?
That's right.
And that's going to help tremendously. And you will see this come and go. And you got to know that that's okay.
Yeah.
Okay. It just means that for whatever reason, you're not stretched enough. Okay. So the next step, if you're like, Maskill, I'm doing a great job stretching, and I am making sure that it's my gastrocnemius muscle that I'm stretching, because that's going to get tight first. Then the next thing that I would do is probably send you to formal physical therapy. Okay. And you say, well, what are they going to do for me there?
Yeah.
Because I can stretch at home.
Yeah.
Okay. And there is a lot that they can do there. Okay. They can do, depending on who you go to, they can do running analysis, gait analysis. And then as it comes to your calf, they can help you with regards to just getting this Achilles to move better within the sheath that it courses in. And they can get rid of some of the inflammation, and they have TENS units that are there, which is more like an electrical type of stimulation, but it will actually interact with the white blood cells and decrease inflammation. And the other, things that they can do microneedling and or dry needling rather, where they're actually trying to once again free up some of that soft tissue, and then they've got ultrasounding that they can do, and they've got basically massage treatments, which again just heavy scraping, and it's all in an effort to diminish the inflammation that's already there, and they can break up some of that stuff.
And most of us will look at something like that and say, it's possible I could probably do that on my own, but chances are I can't do it as well, or I don't have the equipment. A lot of these things require equipment. So the physical therapy option ensures that I have the best possible available to me to address that.
And patients also have a hard time hurting themselves.
True. Yeah.
And so we're our own rate limiting step essentially. So you have a hard time getting deep enough or, powerful enough to actually accomplish what we're trying to do. Exactly. Whereas a therapist, you will be much more allowing him to actually, get the job done, because you can, focus on getting it done, and it's not yourself that's doing it to yourself.
Sure.
So,
well, and there's a layer of like, I trust this person's doing the thing that should be done.
100%.
So it's,
Yep.
That's good.
Absolutely.
That's good. Okay. Well, so what if we exhaust that option?
Yep.
Is there anything else?
So if we exhaust that option prior to, I would say, before I jump into that, the one thing that you could do is immobilization. So, immobilization for me looks like wearing a boot.
Yeah.
Okay. But I would only have you do that if it was a really acute event. Okay. So if you came to me, a couple days and said, man, I had a really long run. I am just really sore. The one thing you could do is maybe just give yourself a short-term amount of immobilization with a boot, where your Achilles is not dorsiflexing and plantar flexing anymore, and you just rest it for a second, combined with probably a full prescription strength anti-inflammatory. So you're kind of hitting it over the head with immobilization, but then you're also taking not just over-the-counter level naproxen, but maybe a 500 milligram.
Yeah. Okay.
And you take it, even if you're not really having any pain, you take it as an anti-inflammatory, not a pain reliever.
Gotcha.
So that will help. But I don't use that very often, because if you have to use it too long, you're going to lose calf mass. Right. And that's going to then alter your run, and then even alter the strength in that one leg.
Yeah.
So, which is super bad to run with an uneven amount of muscle mass.
Yep.
Right.
What's is there a certain number of days that you say try it for this many days, but don't go longer than that, or is it not that simple?
I mean, I would really be hard pressed to take it past a couple of weeks. I mean, I would say about a week or two.
Yeah.
And if things aren't better, then, I would proceed with the next step probably.
Okay. All right.
So the next step, prior to 2021, really, my one thing that I was using very regularly was it's called dexamethasone iontophoresis. Okay, and dexamethasone is a incredibly powerful steroid treatment, and so basically what you do is there's a patch that has a positive and a negative side, almost like a battery, and with the ions that occur there, with the gel that the steroid comes with, it will pull the Achilles through the skin and go directly to the Achilles itself.
So it's like electrically injecting
Yes.
steroid.
Yes.
Okay.
And the one thing you have to remember about steroids, and this is really important to know, is that with steroid treatment, especially to tendons, it is dependent on the speed that you give it and the volume at which you give it. Okay. So an injection, it's a very commonly asked question. Can you just give me a steroid shot, please?
Yep.
So I've had multiple patients, more than I have fingers, that have gotten an injection from somebody, and they make it to the parking lot and their Achilles ruptures off the bone.
Oh.
Okay.
Like right there after the
right
injection.
There. And I'm telling you, they feel great. They're thanking their provider, and they walk out and rupture. I mean, I've literally had that story probably a dozen times in my career.
Why? How does that happen?
It's because the Achilles is really aggressive with tendons, and it can actually just eat right through it. Okay. So you say, why in the world would I even consider doing dexamethasone treatment to my Achilles?
Right.
Well, the difference is because the dosage is markedly less.
Yep.
And then these patches that we're putting on are over the course of 4 to 14 hours. Okay. So it is definitely, I've never once, and I've been using it for well over a decade, I've never once had a rupture of any sort.
All right.
But it does come with some issues. The steroid, obviously passes through the skin. You can get some skin atrophy, okay, where the skin just gets weaker. It's, again, a side effect of, really any sort of steroid, but topical for sure. And then you also can get fat atrophy underneath the skin, underneath the layer of skin. So it just thins it out a little bit. And, you can also get just from the actual adhesive and everything you can get, and having it every other day, which is what I would prescribe it as, you can get reactions to the adhesive, and therefore your skin gets red, it gets blistery, and so on and so forth. Now, I will tell you that people will still use it right and left, and they'll push through those things, but it definitely limits the number of treatments that you can do, and then if you can even have another one.
Right. Yeah.
So, then you ask, like, how many times can you actually do this? So usually I would write that for maybe 8 to 10 visits or treatments. And then a lot of times patients are doing much better, right? But they're not enough better. Or they're like, can I have I need a little bit more.
Yeah.
So we'll do another round. And if you're not better at that point, then it's either let's be grateful for where we're at, or, really consider our options and weigh the risks and the benefits.
Okay. Yeah, that's where you might elevate okay. But you said prior to 2021, when you started talking about that treatment, which suggests to me there's something else.
Yes, there is something else now. So for the past, I mean, it's been in a very short time. Last year, the FDA approved an orthopedic laser that is like a grade 4 laser that pulls out 2 wavelengths of infrared light. Okay. So it basically then interacts with these 2 specific wavelengths. It interacts with the white blood cell by going through the skin at a very at a a very high powered level, and it basically causes the retreating of the inflammatory tissue, and actually then encourages increased blood flow to the area, and it increases the healing ability of the scar formation to form something organized,
as opposed to that like congealed scar tissue.
Yes. And so Europe has been using this for almost 2 decades. And they have, but it takes quite a while to pass anything through our FDA.
About 2 decades, it would sound.
Yes. And they approved it finally in 2021. So in August, so that was about June, in August of 2021, the Academy of Orthopedic Surgeons, our governing body, actually endorsed the laser as a treatment option for specifically plantar fasciitis, Achilles tendonitis. But then Europe has done an extensive amount of research on this, and they've basically bundled really any sort of tendonitis in the foot, ankle, or in the entire body can actually be benefited by this particular laser. And not only that, but as research has gone on in Europe, muscle issues, muscle aches and pains, and anything that basically has inflammation associated with it can be utilized here.
That's amazing.
Yeah. And if the Academy of Orthopedic Surgeons is going to endorse it, it means something, because you basically have to, give your firstborn to the Academy for them to endorse anything. And they do not endorse cortisone usage, for example, because yes, it does work, and they'll never endorse an injection for reasons that we just discussed. But the dexamethasone treatment, albeit it's very effective, it still has fat atrophy, skin atrophy, issues with the tissue, and because of the potency. And so there's always some level of risk.
Yep.
So it's never going to be accepted by the Academy. Right. But now laser is now coming out, is now being made available in the United States. And that has virtually no side effects. So it's light.
Yeah.
And they have specifically taken out 2 wavelengths of light, which miraculously interact with the white blood cells. It's crazy.
Right. So, and the treatment schedule then is something that's a little bit easier to, because you're not worried about things like side effects with,
correct,
or atrophy with.
Correct.
Okay.
Yes.
Wow.
And for the runner, so we can address calf pain with it. We can, because that's inflammatory. We can address the entire Achilles with it. All they do is they increase the size of the actual lasered area. Okay. And there's, no radiation associated with this. And there's, no side effects from getting overexposure, so to speak. It is literally just light. And it's very specific wavelengths.
Yeah. That's amazing.
Yeah.
So how effective is it? Like you're talking about how, certain treatments, certain percent satisfaction, some of those kinds of things. Do you know yet? It's relatively new. How effective?
So, basically we are still getting used to it, because, we're in Michigan, and Michigan just opened up its first center. So, and that was in September.
Yep.
So I've had about 4 months myself of using it.
Sure.
But what it does really stimulate is ideas to study, such as that.
Yeah.
So when it comes down to the literature on this in particular, it's a little bit vague, because we want to make sure that we isolate who they're actually testing as opposed to all comers. For example, like, are we dealing with runners, or what type of Achilles tendonitis is this? Where is it?
Right.
And is it better for others is it better for certain situations versus others? So I'll be honest, because there's virtually no side effects with this, we started, putting patients in this for the same reasons that I would use dexamethasone or the steroid treatment.
Sure.
Okay. Yep. And the patients have been markedly improved, especially when we're talking about Achilles tendonitis, it has been markedly improved if you don't have a spur. Okay. Yep. So a spur is different from a Hageland's deformity. A spur is actually when your Achilles has had so much inflammation associated with it that it creates bone. Yep. The good thing is that most runners don't have that. Okay. And so in difficult situations like a runner, they're difficult to treat because we don't want to hurt them. Yeah. Right. And my job is just hurting patients to get a better outcome. Right. Yeah. And so the runners are difficult. And so I have been incredibly impressed with just the ability to get a runner through it, and there's, we are not dealing with any of the side effects of the steroid or any of the maybe side effects. Yep. Right. So it has been really a blessing to have that and see patients get better. And, typically if it's acute, meaning it just happened relatively quickly. Yep. Or a short time, it's recommended to be about 6 treatments. And if it's a more chronic issue and we have time under our belt that's been allowed to accrue inflammation, then it's more like 12 treatments. Okay.
That's something.
Yeah. And we're hopeful that, in my experience of 4 months, I've definitely seen patients that have gotten they're back to zero pain remarkably.
Yeah.
I've seen some patients that haven't gotten full relief, but I feel like, anecdotally, meaning just by my experience, the improvement rate is at least 85 to 90%. And, now the downside of this whole thing is that you go run again and you don't stretch, you can get it back.
You're coming right back.
Right. And so this is something that we deal with throughout our life, and it's going to happen. So it's not a failure of the laser per se, right, or the dexamethasone treatment, or even your failure to stretch, right? It's something that, our calf gets tight again, and, we just have to maintain.
Right. Well, and if there's anything that equips us to be able to address these things, because we know that you said it, we know that problems are going to happen. I don't think there's a runner out there who isn't intimately familiar with injury or some semblance. We read some statistics recently that it's like something like 50% of runners are hurt at any given moment. And that's, I don't know exactly how accurate that is, but whether it's accurate, it feels about right.
Yep.
So it's the interplay of what should I always be doing is kind of the first layer. We're always trying to figure out the ways that I change my behavior in such a way so that it's less likely. But then also when it's there, what then are my options?
Right.
And being able to just kind of see the scope of, especially with something like, we talk with runners about plantar fasciitis and Achilles tendonitis all day long. And so you have a spectrum in front of you.
Yes.
And, the final solution isn't the ideal one for most runners in most instances, but you can kind of see what it takes to get to that by being able to see the spectrum here and having more of those options in the middle where we just don't tend to realize that there's other things that we can do.
Right. Yeah. I would say too, just make sure that you get on it. Mm-hmm. Like, in other words, when I had the plantar fasciitis, I was like stretching immediately. Yeah. And then you got to slow down. But yeah, none of us are perfect. We're all gonna, have times where we're better at stretching than others. And, we get lazy at certain things. And we all get complacent. But when you get in pain, the one thing I've known about runners is that you guys will literally push through anything.
So we're stubborn.
Well, you guys want to get the job done.
That's right. Yeah,
right.
That's right.
And so you're willing to sacrifice. But the issue is that this is something that can be easily stopped if you stop and stretch and get it under control quick.
Yeah. Yep.
So
it's that, the moment's decision, rarely ever do I achieve something great by going for it in that moment when I should have done something else. So if I make the choice to do the appropriate thing to treat whatever is going on now, I'm likely to thank myself later.
Yeah. And I don't mean to come across like if you feel an ache or a pain in your foot, you got to stop. No, that you don't. But maybe after that run, stretch
Yeah.
and really stretch it, and then see how you do the next day. I mean, if we're in a lot of pain the next day, stretch again, take your anti-inflammatories, and just try and get it under control so that it doesn't accrue.
Yeah.
You know, and I think that is the take-home message. The other message is, if you are still running and you are in pain, surgery is just not in any way, shape, or form for running. Okay. You know, if you're stopped running and you can't run, can't walk, well, now we're in a different scenario.
Yeah, that makes sense. Well, I appreciate immensely, as I said at the beginning, your expertise and enthusiasm, and how these things can help inform better decisions. You know, that's when we try to figure out what can we do that's helpful for our audience. That's exactly it. So thank you so much for your time today, John, and we've got certainly more in store with you. So appreciate your willingness to share on multiple levels. We'll talk again soon.
Awesome. Thank you so much. Thank you for having me.
It was very generous of you, John, to share your expertise on our show. We thank you on behalf of our audience. We also thank you.
And there you have it. The two things that we have to always remember about this kind of stuff is, first and foremost, nothing in terms of the kinetic chain is independent of the other things in the kinetic chain. And so when you start talking about Achilles, and he immediately says early on, he's like, well, you can't separate Achilles from calf, from plantar fascia, because those things are all part of the same kinetic chain. And so in functional movement, they're all interacting. And so as we start to identify, I've got a pain in this area, we should never view it as an isolated thing. It is a part of a process, and we have to be addressing these things from a bigger picture point of view. And I think that's one of the biggest takeaways I had as I was talking with him then, and as I've reflected on what it looks like to try to stay healthy and strong. The concept of general strength and mobility exists at a high level of priority for runners for a reason. And so thank you, John, for the advice. And if there's one takeaway you should have all heard, it was, if you've got concerns about Achilles and plantar fascia, you better be stretching your calves. Principle number 1, among other things. Well, that was good. Speaking of good, let's go ahead and get on now to the world of running.
For all those crazy, amazing runners out there,
Cramazing.
some of which are A to Z runners, we congratulate you on your Groundhog Day half marathon,
Whatever
and 1/6 marathon events. Ben did the half marathon. Mark did the half marathon and was third in age group. Julie, half marathon, first in age group. Lewis did the 1/6 marathon and half marathon as well. He doubled up there. And Brandon did the half marathon, fourth in age group and 14th overall.
Nice work, everyone.
Yeah, especially because even though there was sunshine, which does make things slightly more pleasant, the footing was still difficult, and it was a very cold day.
It was like 9 degrees.
It was very cold.
Not including wind chills. So, yes, it's very cold. But, if you're going to run a race in early February in Michigan, you're just, bringing it on yourself.
These folks know what they're up against because they're Michigan runners, and obviously they're doing long runs in this kind of weather. But very impressive and cool event, really, to be part of. It's a very special group of very tough runners.
That indeed is true. Mm-hmm. Well, speaking of a special group of interesting things, first up on the list here is an interesting policy with Boston Athletics Association.
I feel like it's so delayed to get to the policies that I think all races should probably have some sort of answer for you about, and that is the Boston Athletic Association announced a pregnancy deferral policy.
That's Boston Marathon and a few other big races.
Yeah. So according to Women's Running, the Boston Athletic Association announced a pregnancy deferral policy effective immediately that would allow any athlete who is registered in any BAA event and becomes pregnant prior to race day to defer into one of the next 2 subsequent future races. Athletes can request deferral up to 2 weeks before race day.
Okay. So when you're within 2 weeks, you're no longer going to...
But this is so interesting because when you try to defer... The 2 checked boxes are illness and major injury, which does not include pregnancy. And there's a lot of women who, go through pregnancies. So it's kind of interesting that it's just now being truly addressed in a direct way. So this, I should say, the Boston Athletic Association does have an insurance policy that one can buy that does include pregnancy deferral, but that means that you would know, in advance if you were going to be pregnant, and sometimes you don't know. And then also that's just another thing that someone would have to buy, the insurance policy for, that really discludes, a lot of people.
Yeah, part of the issue with these types of policies not existing in the past is that the assumption, and it's a reasonable assumption, but the assumption is this is something that tends to be deliberate as opposed to illness and injury, which, of course, you're not intentionally hurting yourself. Now, that being the case, of course, plenty of pregnancies are not deliberate.
Well, or it takes a long time, so you're not going to stop doing life when you're
all those things aside, is it not simply true that over the course of you are planning to run a marathon and maybe you decide you do want to be pregnant and that was a decision that happened after the marathon.
Yeah, you should have to decide.
Why is it not something that you can just simply at any point in time say, well, this is now the current state of things and I want to defer that entry?
Yeah.
I think that's always a reasonable policy to have.
Yeah, and I don't have the exact words from the organizers of Boston Athletic Association in this deferral policy, but they said something to the effect of that they don't want people to have to choose between family building and then also pursuing these running goals, which I think was a really great thing to say in regards to this. Fiona English, it was the one who kind of brought this up to the attention of many because she got a 17-minute PR, finally qualifying for Boston. It was a very long journey to get to that point, and she ended up getting pregnant and then was not able to because she didn't buy that insurance policy. She wasn't able to even get a refund, I guess. Eventually, they did give her a refund, and then now they're allowing, because of this new deferral policy, entrance into the next Boston Marathon if she does choose. Now, London Marathon had the pregnancy deferral policy as of last year, and then this year, Berlin Marathon instated a pregnancy deferral policy. The other two major marathons, Chicago and Tokyo, do not have a policy in place right now, as far as we know, but that could change in the future. I think it's just good to have something clear out there because it's a very common thing. So we should have some direction in regards to what one should do if they do get, pregnant. So.
And it should be noted that many races, marathon majors notwithstanding, don't have specified limitations on their deferral policies. It's more general. And so in many instances, you could defer a race entry because of pregnancy, where it wasn't necessarily one of the check boxes.
Right.
So now it's just making it more clear as an option.
Right, because
in
a
some
lot of
races
people
it wasn't
would
before.
get the deferrals for various different races by clicking illness or major injury, which that's not pregnancy. Pregnancy is neither of those.
No.
So you shouldn't have to check something like that.
Plenty of instances where pregnancy
causes
comes with illness.
Well, I know that firsthand.
Injury. Yes.
But I'm very excited that this is now something that's being addressed and we can see this policy in place, and that's very hopeful for mamas who want to continue on their pursuit of the sport of running.
I'm a fan.
Me too.
More the better. All right, so now number 2 on our list here is some interesting race results. So the New Balance Indoor Grand Prix is a reasonably new event. Well, actually, they've had the event elsewhere.
Elsewhere, yeah, because
it's at a new location.
Yeah, new location.
It's a new location.
Old event.
This is the second year that they have run on what is called the track.
The track.
They're just entirely not creative with naming track facilities.
I think that's boisterous.
Boisterous?
Yeah, it's super bold. This is the track.
That's what they claim. New Balance built this facility in Boston in 2022, or finished building it in 2022, hosted their first event. And naturally, in their first hosting, they had things like the distance medley relay world record and things like that, which is fun, set by the New Balance team, of course. So this is the second year on the track, and it's a world-class facility there's no doubt about it. But in this particular instance, one of the things that I think is just the best thing about it is they sold out the meet attendance, which does not happen, at least in the U.S., in indoor track especially. And so for them to be able to say, we've got 4,000 people in this stadium for this indoor track meet is just, I can't imagine what that sounds like. Outdoor stadiums with tens and tens of thousands, that's something. But when you're indoor and the sound is just so close to you.
I'm sure that it's also reverberating around.
Oh, that's got to be something.
Usually facilities are made with a lot of hard surfaces.
An indoor track facility is like just concrete walls and rubber floors. So, all right. Well, anyway,
love to run there.
That had to have been exciting, and one of the reasons we know it must have been exciting is because how many people ran personal best times.
Yeah, it must have been an electric atmosphere
like that. Speaking of, the women's mile was one of those events. 8 of 10 finishers in the heat. Well, there were only 10 total, so all 10 finished. But 8 of them ran personal best times in the mile in Heat 1, including a world-leading time by Heather McLean of the USA. She ran 4:23, which is a continuation of what was an incredible season last year.
Yeah.
So she's just raring to go right out of the gate, and I believe this was her opener, certainly in the mile at least. So a tight finish, by the way, then over Canada's Lucia Stafford, who we mentioned last week, had a very strong 3,000
North American record.
Very strong.
Or no, not 3,000. I'm sorry, 1,000. Right?
1,000.
It's a 1,000.
North American record.
So she's from Canada.
Yep. And so the two of them ran very tight finish, like leaning across the line kind of tight finish, which is exciting.
I love that. It's fun.
Very nearly leaning across the line. But then there were also national records from Spain, which is Esther Guerrero, or Herrero, however you say her name, 4:24, and Japan's Nozomi Tanaka in 4:28.
Oh, I love that. Two national records. In a group of 10.
And only 10 racers.
Records. Oh, my goodness. That is amazing.
And some just incredible stuff from others as well. And then we should mention there were some in the race, one like Emma Coburn, who ran a personal best mile, but it was kind of like, I was just kind of like opening up my season, trying to see how I feel. It's like, clearly that was an exciting race.
Clearly it was good.
Now, Emma
these
Coburn,
are like professional runners, and for them to get personal best times right now is really insane.
Yes,
I think.
But Emma Coburn doesn't ever run the mile, so I don't know why.
Like she did some leading into the Olympic year.
Every once in a while she does it.
Yeah.
But she did it here because she's sponsored by New Balance, and this is New Balance's track, and so New Balance is like getting their people to say, you got to all race here. But she's also planning on running the World Cross Country Championships.
I'm excited for that.
In a week or two, whenever that is. And so it's kind of like, just to get freshened up for that, I'm going to run a mile on the track, on the indoor track, nonetheless. In the men's 3,000 meter, exciting things were happening too. Speaking of Woody Kincaid and his national record performance last weekend, he ran another great race, not quite to the level of record breaking, but closed out in a vicious finish and just trolloped the field with his final 200-meter
that's
kick.
What he does.
Just what he does.
Vicious finishes.
Yep. So he won another race, which is good stuff. He ran a personal best time in the 3,000, 7:40, very respectable, and led a field to 8 of 10, again, finishers to run personal best times. No records this time, but they were all very fast. So that's exciting.
Certainly.
And then in the women's 3,000, half the field ran personal best times, with Laura Muir winning in a very strong performance up front as well. Laura Muir of Great Britain.
Front. She's often up front.
So we'll see what she does indoor. She sometimes
what event you
focuses
think she'll do?
Different kinds of things. 3,000 is long for Laura Muir. She usually stays closer to the mile with stuff. So we'll see.
It'd be interesting. Now the London's women's marathon. What did I just say? London Marathon women's field is absolutely exciting, and I'm going to be watching this race. I'm going to find a way to do it.
Well, with an April marathon, and we're talking about February right now, there certainly are changes that are going to happen. It's always the case, whether it's because people get hurt or people just aren't quite ready for the race after all. Also, I don't know how London can afford, I've said this already once this year in the fall, with the marathon majors races with so many elites and so many world-class runners. Like, how can they afford this? Because they have to pay them entry fees, or appearance fees rather. And so because they're paying appearance fees, now we're talking about they have pretty much all the best women's marathoners currently running the marathon in one race. I don't know how they can afford that. So we'll see how that pans out too. But
bonuses
let me give you.
So I'm sure that everyone's kind of looking at the field and saying, okay, well, maybe you're not giving me as big of an appearance fee, but I could get some bonuses if I hit certain times or
It's a
records.
question I'd love an answer to, but they're all done with non-disclosure agreements, so no one's ever going to talk about it. But speaking of, there are in this field 11 women with PR marathon times under 2:20. And of those PRs, almost all of them have happened in the last year. So they're all currently some of the fastest marathoners of all time. And then of those 11, four runners are as well in the field record holders for their area or the world, speaking of Bridget Koskei. So Bridget Koskei, who is Kenyan but also holds the world record. And then America's Emily Sisson with the USA record, as well as USA's number 2 all-time, Kiera D'Amato, both in the race currently. And Australia and Canada's national record holders are in the field as well. So that's exciting.
Ooh, Genzebe Dibaba.
Yeah.
Who's only her first marathon was 2:18:05. She's only run one marathon. So
and that was in 2022.
That's
so
a crazy debut.
Just getting started.
Yeah, for sure. Like there's a learning curve.
Well, I mean, speaking of crazy debuts, in this field, Yalamzurf Yahwala of Ethiopia is in the field, and she ran her marathon debut in the last year.
Faster debut.
And ran the fastest debut of all time at the time. And then, not long after that, Almaz Ayana of Ethiopia ran her marathon debut 3 seconds faster than Yahwala. And so she broke the all-time debut record. And then Letezen Begide broke that as well later on. But she's not in the London field. She's like the only one of the ones we've been talking
quite
about.
a few of these, let's see, 1, 2, 3 have only run one marathon before this.
Yeah.
So this is going to be interesting because of tactics involved. And are they going to try to take it out, these more youngster type runners? Are they going to take it out, or are they going to like kind of sit on Perez Tipchirchir, for instance? Like, I don't know. We'll see.
We will see. But there are some other interesting facets here because there are some debutantes as well who have some promise. Speaking of Eilish McColgan, who is going to...
You said that like in a tentative way. They definitely have some promise.
Well, but they've never run a marathon before, so you never know what's going to happen. But Eilish McColgan, of Scotland, was going to debut last year, if you recall, was it Berlin?
I thought it wasn't in London.
No, because London's in the spring and that was a fall. Where was it? She was going to debut.
I thought it was in Europe somewhere.
Berlin is in Europe. So it could have been there.
I know.
Anyway, so she didn't because she was dealing with some injury stuff. And so now she's planning to come back in London this year. And Andy's right. It could have been London last year. I could be just misremembering the timing. But Eilish McColgan is not planning to be full-time marathoner at this point in time. But it kind of depends on how things go. If the marathon goes really well for her, maybe she will.
Right. And it's funny because I read a quote that her mom said that she would be a marathoner and told her that when she was 12 years old. Her mom being Liz McColgan, who was the previous record holder before her daughter broke all of her records.
Yeah, and everything.
And a lot of events.
Yeah. That's always cool. Kind of fascinating. Well, it's a good prediction, though. If you watch Eilish McColgan run on the track, you get the impression that she's not quite the same kind of runner as some of the other track runners. But then when you see her on the road, she just looks like it's just her spot, natural.
She looks so eager when she runs. She looks like she's eating the road up.
Okay, that's probably
she's got like a slight forward lean, and she just looks like she's eating the road up is the best way to put it.
Even at the end of races, she actually gets down and takes a bite out of the concrete.
Stop.
It's really quite
Too
impressive.
far.
So Sifan Hassan, who held the world record in the 10,000 before it was broken a week later by Letezen Begide, and currently holds the mile world record, right? So her range of track stuff is quite large.
Multi-time Olympic champion, and
is making or will be most likely making her marathon debut in London before starting her summer track season. So her comments here are just hilarious when you see her talking about it. So basically, you can sum it up for Sifan Hassan in terms of what she's doing here with one word: curiosity.
I love
in her own words, she's just interested to find out. So her quote was, "I can't just dream about it. I will know," meaning I will know what the marathon is like and what it's like for her specifically.
Yeah.
So I find that to be just fascinating.
I love that. Sheer curiosity. I would say that is one of the reasons that I did the marathon was curiosity. Just what can I do? What is it like?
Also because you said to everyone who would ever listen that you would run a marathon after you had your first baby.
I mean, I didn't say that my whole life long, but yeah, there is a curiosity. That's why. That's not what I said. I'm talking about the motivation. The motivation is not because I told people. It's because I had curiosity.
Well, okay. So Sivan-san has done things that other people would never even attempt, like the triple in the World Championships. If you recall, she attempted the 1,500, 5,000, 10,000 triple. So she clearly is willing to suffer and willing to do uncanny things. But does that translate to, fast marathoning? Who knows? She's not just fast on the track. She's run 65 minutes in a half marathon as well.
Right.
And so has the potential, absolutely. Just, you never know.
Yeah.
We're just very excited to find out. So part of it is like, you have to hope that things go well in preparation so that she actually does have an opportunity for a good test of her marathoning potential.
Mm-hmm. And I believe February 11th, perhaps, is when Millrose Games begin. So we're going to have a lot more track coming up for you, too. And then these road races that are beginning for the spring coming up soon as well. So stay tuned for more World of Running news next week.
And that being said, we should probably remind you that we are here to help you in any way that we can and interact with you in any way that is convenient. So post the comments, ask the questions, and if you're not finding enough in the content to do what you need to get to where you need to get, check out our support services. You can find all of the options at AtoZrunning.com/coaching.
Well, thank you all so much for joining us, and we'll talk to you next week.